record on this computer. Okay. So acute care of any baby composed of a block of time. Okay? And usually and please don't text, just chat with me. I don't like texting because I am busy. So kindly and please, please and please do not text. If you have something, open your mic and talk to me. Because I don't have time to go to the chat. Okay, so acute care of any sick baby, whether it's a child or a newborn, it's a block of time. And this time composed of evaluate, identify, intervene. Usually in child, it's 1 to 2 minutes block of time. In a newborn, it's usually 30 seconds. So our initial assessment, our evaluation was whether the child is breathing, whether the child is conscious, and what is the color. And based on that, we react. Do you guys remember that?
Yes, yes.
Okay, so after that, we have either arrest or heart rate less than 60. In both, we do CPR until child regain consciousness. Or no, his heart rate more than 60 and he has breathing, so we give respiratory support and oxygen. After that, we re-evaluate again. So that will take from us 1 to 2 minutes. So our second evaluation, called primary assessment, and the third one called secondary assessment. So primary assessment also evaluate. So how we evaluate? We evaluate A, B, C, D, E, F of respiratory system, cardiovascular, and neurology. Our secondary assessment called AMPLE, which is focused history and examination, and we'll talk about it. And then we do diagnostic testing, which is including lab, radiology, whether it's ultrasound, CT scan, MRI, and it might involve other advanced radiological testing or lab testing. So that's in general how we take care of sick child. Any questions so far? Questions?
Doctor, but we also evaluate for the airway in previously, and for in the initial impression also.
So our initial, remember, our initial assessment is 3 questions. We said breathing or not, what is the color, and conscious or not. So for
Yes.
breathing, we said 3 things in the initial. We said, what is the breathing pattern? What is the type of the breathing sound, whether it's a vesicular or bronchial, and if there is added sound. So these are 3 things we talk about breathing. About consciousness, we said 3 things also. Either conscious, or irritable, or alert. Yani unconscious, irritable, alert. For the color, we said pale, mottled, cyanose, gray. So these are our evaluation. And then we identified either breathing or not breathing, heart rate, arrest or below 60 or above 60, if you guys remember, right? And intervention, either CPR or give oxygen and ventilatory support. Then we move to next evaluation. So that was our initial evaluation. Is that clear? Any question? Questions? No answer? Questions? No questions? Okay. So our first evaluation, called initial evaluation, composed of evaluate, identify, intervene. Our second evaluation, called primary assessment. Our third evaluation, called secondary assessment. So now we will move to our secondary assessment. For the respiratory problem, we identify, is it upper airway? Is it lower airway? Is it lung tissue disease? Is it disordered controlled breathing? That's our identification. Our evaluation will be A, B, C, D. For the respiratory, our identification, either upper airway obstruction or lower airway obstruction, lung tissue disease, and disordered controlled breathing. Identification from that, either respiratory distress or respiratory failure. For cardiovascular, once we do A, B, C, D, E, F, we decide either hypovolemic shock, distributive shock, cardiogenic shock, obstructive shock. So that's our identification. And then from these, we decide whether we are in compensated shock or hypotensive shock. All of these will lead to cardiopulmonary failure and then cardiac arrest. They might present alone or in combination. And sometimes we are uncertain why this happened. Uncertain of the type and also uncertain of the severity. So this is our identification in the primary assessment. Our intervention in the primary assessment, we position the baby for the airway to open the airway. We give oxygen. We do ventilatory support, and we might give nebulizer or inhaler. For cardiovascular, our intervention, either we do CPR or we just monitor the heart and saturation. We might give IV fluid through intravenous or intraosseous. Of course, if we did not activate emergency response, we should do to call the rapid response team. And if we don't have one, then we shout for help. Okay, so we remember again. Evaluate, identify, intervene until we are stable. Evaluate, identify, intervene before and after any intervention. Evaluate, identify, intervene with any change of a change of the finding. Now, we always, when we identify a problem, we should say, is it life-threatening or not life-threatening? In our identification of the primary assessment, remember, not the initial, it's the second block of time, our life-threatening conditions are absent or agonal respiration. What is agonal? Anybody knows what is agonal? agonal respiration or بالعربي نازع أو يعالج is irregular occasional breathing or breath that is not resulted in gas exchange. Absence of respiration or agonal respiration, that's life-threatening condition. Respiratory distress is life-threatening condition. Cyanosis is life-threatening condition, and decrease or change level of consciousness. So always when you evaluate, identify, we always have to say whether it's life-threatening or non-life-threatening. So when we evaluate, after each intervention, when condition change, whether it's improve or deteriorate. What's our cycle? Evaluate, identify, intervene. How long? It should be take 1 to 2 minutes. When it's a newborn, it should take 30 seconds. Okay, so remember, our primary assessment composed of A, airway, B, breathing, C, circulation, D, disability, E, exposure. So let's start with the first one, airway. Airway, when we evaluate airway, we don't need any. Is it patent or not? Is the airway patent or not? So when somebody, oh, the airway is patent. Second, is the chest and abdomen moving or not? Is there air entry? Is the air moving? And what is the breath sound? So that's our evaluation about airway. Is it patent or not? Is the chest moving and the abdomen moving or not? Is there air entry or not? And what's the breath sound? Is it bronchial or vesicular? And we talked what is bronchial, was vesicular. Our identification will be clear, maintainable, not maintainable airway. Clear, maintainable, not maintainable airway. Any question here of the primary assessment of the A? It's very important to ask questions and discuss with me, because I don't know if you guys are understanding, not understanding. Okay?
Sorry, but what do you mean by maintainable and not maintainable?
Maintainable, that with support, the baby can breathe. Not maintainable is without support, the baby cannot breathe. So when you say maintainable, the baby can breathe without active respiratory support. Active mean you give support, whether invasive or non-invasive. Not maintainable means without active respiratory support, the child cannot breathe. Clear?
Okay.
Means
Yes.
there is no problem with the breathing. Maintainable with some help, mask, positioning, the child can breathe. Once you change that position, child cannot breathe, but the child can maintain breathing without help. Not maintainable means without active respiratory support, the child cannot breathe. Okay, so our evaluation is these three in the airway, and the result should be there. We don't need to think. You just say clear, maintainable, not maintainable. Okay, and we'll take it in detail. Okay, so what's the clear? Let's answer your question. Mean open, non-obstructed. What's maintainable? Mean can be opened by simple measure, such as head tilt, chin lift. Head tilt, chin lift. There is something here called sniffing position. Do you guys heard about this position? Anybody heard the sniffing position?
I think for adult, not for the pediatric.
Well, what is a sniffing position?
Somewhat
Whether it's adult, yeah?
extension of the head.
Extension of the head. This is Sarah. Sarah, you're very good. You'll always participate, which I like, which you'll be very good intensivist. That's good. If you know or you don't know, you participate, and that's how you learn. Any other comment about sniffing position?
Because sniffing position, it is flexion of the neck and extension of head, isn't it?
Okay, so it's extension of the neck and extension of the head. Okay, you guys know,
Flexion
but
of
it's
the
like
neck, extension of head. Flexion of neck and
flexion of the
extension.
neck, extension of the head. You
Yeah.
guys know, but like it's a cloudy knowledge. You're not sure exactly. Anybody there? Any than Isra and Tafja? Anybody have any comment about sniffing position? So sniffing position is as the following: the tip of the nose and the tip of the chin on the same level. So if you put like a ruler or a wall or a plate, okay, so the tip of the nose and the tip of the chin should be on the same level, horizontal level. And when you do this position, the airway will be aligned. So the larynx, the pharynx, the mouth will be aligned and the airway will be open. Again, the sniffing position is as if you sniff. So when you sniff, you extend your neck you extend neck anteriorly, you pull neck, and then you pull your chin up a little bit to be at the level of your tip of your nose. So sniffing position is the tip of the nose and the tip of the chin on the same horizontal level. And when we do that, that means the upper airway will be aligned and will be open. So maintainable is easy to open the airway by simple measures such as head tilt, chin lift. Not maintainable need advanced airway intervention such as endotracheal tube. So our evaluation was patent or not, moving chest or not, air entry or not, breath sound there is or not, and then our decision is clear, maintainable, not maintainable. Questions? Okay. So what are the simple measures that, because we said evaluate, identify, intervene. So if it's clear, no need for intervention. If it's maintainable, these are our intervention, which is position of comfort. So baby can be standing, sitting in his mother lap, or maybe we do head tilt, chin lift position. In C-spine injury, okay, we have to be careful. And when the baby is infant, less than 1 year, we have to do jaw thrust. All of these we'll know exactly. We will discuss it in details. Avoid hyperextension. Avoid suctioning. There is no need for suction during resuscitation. Neither in newborn babies nor in adults. No need for suctioning. The suctioning are harmful. It's not part of resuscitation. Why it's harmful? Because of the following. First, it takes loss of time. Second, it causes injury. Third, it stimulates vagus nerve. And when you reach to the stomach in a newborn, you take important nutrition from the baby, even if it's blood. Even if the baby is bleeding, you don't need to do stomach wash. That is not part of resuscitation. It is wrong. You don't need to suction. When the suction is indicated in two possibilities. You want to intubate and you cannot see, and you want to use CPAP and it's obstruction. That is the only way you need to suction. And if you suction, you only suction the nose and the mouth. You don't go beyond the tongue. Do not suction the nose. Do not suction the oropharynx.
Dear doctor, what about in cases of chest infection when the baby has a lot of secretions?
No suctioning. The suctioning indicated only if there is obstruction or you cannot intubate. If you want to suction and there is secretion, you only suction the mouth. You don't suction the nose. You don't pass the tongue. Yes, Hannah, tell me. You raise your hand. Hannah or Hannah? Okay. So you do suction. Also, if there is obstruction, you do foreign body removal. We'll talk about it. Okay. You might use airway adjunct, such as nasopharyngeal airway or oropharyngeal airway. All these are simple measures to open airway in identification of maintainable airway. Any question? Okay. Now, simple measure, remember that we said foreign body removal when suspected or no sound. In less than 1 year, we put 5 bag slabs and we do chest thrust. We will show you the procedure, the maneuver, how we do it. In more than 1 year, we do abdominal thrust, and we will talk about it. These are all considered simple measure. Advanced intervention is ETT, you intubate, CPAP, use laryngoscope, And if it's not, we use cricothyrotomy, whether needle or surgical. Whether it's maintainable or non-maintainable, positioning is always needed. Now, any question about the airway? Assessment, identification, evaluation. Any question, please, if you have anything in your mind, even if you think it's a stupid question, just ask it, please. Because with the question, I know what to say. Questions? Okay. Now we do breathing. A, B. When we assess breathing, we assess, because remember, evaluate, identify, intervene. Our evaluation will be respiratory rate, respiratory effort, whether there is increased work of breathing or not, chest expansion and air movement, lung and airway sound, and oxygen saturation by pulse oximetry. Okay, so the first one in our evaluation is respiratory rate. You know that the younger you are, the faster you're breathing, and the older you are, the slower you're breathing. So you just no need to memorize it, but we start from 60 and go down to 12, depending on the age. Okay, so that's our first evaluation, respiratory rate. You don't need to count over long period of time. Count over 30 seconds and then multiply it by 2. Count several times. When you use the monitor, you don't go to one reading. You observe the monitor for a long period of time, because monitor calculate rate by 2 events. Okay, so the monitor can count the time between 2 rate, and then 60 divided by this time, it get the rate. So the monitor might be wrong and goes up and down. Again, the monitor count the time, calculate the time between 2 rates, and then divide 60 by this time, and the monitor got the rate. So you just not mention one rate. Always also ask the nurses when they do monitoring of breathing, they don't tell me the rate right away. They have to go the meaning over time, 1 hour, over 2 hours. Okay? The most important things also to remember about monitor is you have lag time. And each monitor, there is lag time. And the lag time can be long, can be short. And please, on your profile, write your full name. When there is lag time, so the list lag time may be 1 second, maybe 2 seconds. So when you see the rate on the monitor, it's actually 2 seconds earlier. So there is lag time. The less you're sampling, so if you sample every second, that means you get 60 numbers over minute, is different when you sample 120 numbers. That means 1 number every half second. The more you sample, the more you lag you have. The less you sample, the less lag you have. So if monitor sample 30 times per minute, the lag time between the number and the reality is short. When they sample 60 times per minute, the lag time will be long. When they sample 120, the lag time will be more. Do you understand this? How monitor calculate the respiratory rate? Guys, talk to me, please. يا شباب تكلموا معايا الله يستر عليكم.
Yes,
Yes,
doctor.
clear. Yes, clear. Yes, doctor. Yes.
Okay.
Yes.
So count over 30 seconds, multiply by 2, do it several times. Don't take one number from the monitor, and know how the monitor, look at your monitor, know your sampling time, and know your lag, and please take it over time. Okay. Now we say the rate is ranging from 60 to 12. So anything above 60 is always abnormal. anything less than 10 is always abnormal. What are the causes of tachypnea? Why? If the, because now we're evaluating the heart rate, so we have either we have tachypnea or bradypnea. So what is the cause of increased respiratory rate more than 60? Fever, pain, metabolic acidosis, such as in DKA, dehydration, sepsis, congested heart failure, severe anemia, some of the cyanotic congenital heart disease, or if you're giving medications, such as, for example, dopamine or even dobutamine or vasopressin. So medications, infusion, especially when you use it as a inotropes for the heart, it can cause tachypnea. The bradypnea, not bradycardia, sorry, this is wrong. Anyhow, I change it later, that's okay. It's not working. So this is bradypnea, not bradycardia. Muscle fatigue, central nervous system injury, whether it's poisoning or trauma, infection, hypothermia, medications, severe anemia, some cyanotic congenital, and remember, bradypnea is very ominous sign, because after that you will go to gasping and agonal breathing. Question? Okay. So,
No.
what is apnea? Apnea is cessation of breathing for 20 seconds or less than 20 seconds if associated with brady, desaturation, cyanosis, or pallor. So apnea is cessation of breathing for more than 20 seconds. And if it's less than 20 seconds, it's also consider apnea if associated with brady, heart rate drawdown, desaturation means saturation below 91 in newborn baby and below 94 in term and children. Or cyanosis appear, and remember cyanosis 5 grams, and the saturation will be depend on the part of it, or there is pallor. Apnea can be central, can be obstructive, can be mixed, and we will learn how to treat it and how to prevent it, whether a newborn or child. In future, inshallah, when we go further in intensive care, we will know how to prevent this happening. Any questions so far? And please, this is not bradycardia. This is bradypnea. This is wrong spelling. Questions? Okay. And remember, we said apnea, and after apnea, we have agonal gasping, or يعالج, which is an occasional breath that does not provide effective ventilation. Effective ventilation is when there is gas exchange. The second of breathing after the respiratory rate is respiratory effort. So why, when the respiratory effort increase, when there is increased resistance, such as asthma or bronchiolitis? And asthma and bronchiolitis affect the upper airway or lower airway?
Lower airway.
Lower airway. And when the lowest diameter of the lower airway occur, if you remember yesterday, the first session discussion, which part of the respiratory cycle the lowest diameter occur on the upper airway? When the chest pressure become high. So when the chest pressure become high, it compresses. And when the chest pressure high, when we breathe out. So the lowest diameter of the lower airway will be during expiration. And that's why asthma and bronchiolitis present mainly during expiratory phase. So we breathe like that in asthma and bronchiolitis. Okay, while the lowest diameter of the upper airway is during inspiration. That's why we breathe like that. Okay. Okay, and even if there is a recession in lower airway occur during expiration and in the upper airway occur during inspiration. Okay? When the lung becomes stiff, the chest becomes stiff, when we have pneumonia, when we have edema, when we have effusion. But also increased respiratory effort can be with non-respiratory conditions, such as diabetic ketoacidosis, such as salicylate poisoning, such as inborn error of metabolism. Okay, sign of increased respiratory effort, flaring, nasal flaring. And usually nasal flaring occur in the ali. The calamilla of the nose does not affect bile flaring. Only flaring affect the ali. So you become flaring of as if the nose wanna fly. You get retraction because you're using the accessory muscle. So you get subcostal retraction. If it's expiratory, it's lower airway. If it's inspiratory, it's upper airway. You get substernal retraction and you get intercostal retraction. Mild, you diagnose. If you get supraclavicular, suprasternal, and sternal, you get severe. You can use head popping. That's when you're deteriorating. And then you become seesaw respiration. You guys know what seesaw? Anybody know what is seesaw? No. Seesaw is merjuha. Up and down. Seesaw, up and down. So you get seesaw respiration, fast and slow. That means more deterioration. Okay, means severe obstruction, mean lung tissue disease, and it can be disordered control of breathing. It can be neuromuscular disease that resulted in fatigue. Please remember whether it's prolonged expiratory or inspiratory time. And remember if the child is opening his or her mouth. And remember what's gasping. What's gasping? Anybody remember what's gasping?
It is brainstem reflex.
Gasping is what? Sorry again. I didn't hear.
It is a brainstem reflex that before the patient became apnea.
Okay, so gasping is irregular, occasional breath that is not resulted in gas exchange. Okay, it's called also agonal breathing. Gasping is agonal breathing, which means irregular, occasional breath that is not resulted in gas exchange. And use of accessory muscle, grunting. Do you guys remember what's grunting?
Grunting,
remember?
it was after inspiration, we have a pause, then expiration.
Yes, so it's reverse of respiratory cycle. Remember grunting. Reverse of respiratory cycle. Grunting is reverse of respiratory cycle. So normally we inhale, exhale, and pause. So we do like that. And then we pause. Because our lung will never stick. In grunting, there is no surfactant. So we exhale, then inhale, then we pause. So we do like this. So we pause after inhalation. So what is the grunting?
Reverse of the respiratory cycle.
Okay, so when there is grunting, means there is no surfactant. Remember, grunting is not respiratory difficulty. Grunting is reverse of respiratory cycle, and it means there is deficient or absence of surfactant. So either RDS or adult RDS. And it's life-saving. When you see grunting, you need intubation or you need surfactant. Okay, any questions so far? So our secondary our primary assessment composed of evaluate, identify, intervene. We talked about upper airway, and then we are talking about breathing. We talked about the rate, and now we're talking about respiratory effort. Okay, so the obstruction can be upper airway. So we got what we call stridor. What is stridor? Inspiratory sound. Okay, and it's mean upper airway. And we know what's upper airway. Upper airway, any airway passages above thoracic inlet. Upper airway is surrounded by atmospheric air. Lower airway is below thoracic inlet. It's surrounded by negative
By
thoracic
negative
pressure. Okay, so stridor is upper airway, mean all the airway above the thoracic inlet, surrounded by atmosphere. Wheezing is expiratory sound. It means lower airway. When we have grunting and labor breathing, it's a tissue disease problem. It's not respiratory difficulty. Remember, the tissue has a problem. And whenever the tissue has a problem, such as pneumonia, because pneumonia is a protein and fluid, once it's mixed with fat, fat diluted and decrease the surfactant. And that's why we get grunting. When we have seesaw breathing, the breathing become up and down, mean there is strong diaphragmatic contraction. It's a stage before bradypnea and agonal breathing. Okay, we're still in the breathing. We talked about heart rate. We talked about respiratory effort. Is there any question about respiratory rate and breathing effort? Remember, we have initial
No, sir.
assessment. Do you have a question, Sarah?
No, doctor, no.
Okay, so remember, we have primary assessment, we have initial assessment, and now we are primary assessment. We have evaluate, identify, intervene. Okay, so there is somebody called mine. Yani, what is the name of mine? Yani, how I know who's this person? He's a secretary. Is he part of you? Is he a doctor? So please, your profile name, you should be your full name, please and kindly. I know you are not used to this. I can understand, but I will, forget this 1, 2, 3 times. But next time, please and kindly, so I can communicate with you. I read your name. So, if your heart respiratory rate, your breathing effort. Now, your chest expansion and air movement. The tidal volume in children is 5 to 7 ml per kg. So the child, if the child is 10 kilograms, so he's taking 50 to 70 ml. So that's adequate tidal volume when we look at the monitor and the ventilator. It should be symmetrical. When you assess chest expansion and air movement, you should uncover the baby. And include the abdomen when you have a baby less than 1 year, when you check chest expansion and air movement. So this is your evaluation. When you identify inadequate expansion or asymmetrical, the causes are inadequate effort, patient is tired, there's airway obstruction, maybe there is atelectasis, or maybe there is pneumothorax, there is air around the lung preventing the negative pressure, and that's why the patient will not breathe. There is not hemi, there is hemothorax, not hemi, wrong. There is pleural, there is blood around the chest. There is pleural effusion, there is fluid around the chest. There is mucus plug, or they might be foreign body. All cause inadequate expansion and or asymmetrical expansion. When you check the breathing and you are looking to the chest expansion, please listen to air movement or breath sound. And when you talk to me, you have to tell me 3 things. Air entry, good, poor, or fair, or absent. Good, fair, or poor. or absent? Second, what is the breath sound? Is it vesicular or bronchial? Third, is there added sound? Stridor, rails, crackles. Is it symmetrical or asymmetrical? And you always listen at the axilla in both sides. Okay, so what are the abnormal sounds? So we talked about air entry, fair, poor, good, absent, symmetrical, asymmetrical. And we talked about abnormal sound. So it can be stridor, which means inspiratory sound. Causes are foreign body, infection, allergy, congenital, or medical procedure. Grunting is either small airway or alveolar collapse, or both. It can be due to pneumonia. It can be due to adult respiratory distress syndrome. It can be congested heart failure. It can be due to bowel obstruction, compressing the, it can be due to perforated viscous. It can be due to appendicitis because of pain. It can be due to peritonitis. Gargling means there is secretion in the upper airway. So it can be secretion, can be vomitus from vomiting and blood. Wheeze, expiratory sound, can be asthma, can be bronchiolitis, can be foreign body, can be mucus, blood. Crackle, rail, mean fluid in the alveoli, can be pneumonia, can be edema, it can be interstitial lung disease. And we will talk about what is edema and what's interstitial lung disease and what's pneumonia. We will define that later. Okay, and what is minute ventilation? So we talked about in each respiratory cycle, we have 5 to 7 mil, and in a newborn, it's 3.5 to 5. But we're talking about a child, so it's usually 5 to 7 mil per kg. Okay, that's what we call it tidal volume. It's number of air or amount of air entering the lung during inspiration. And usually it's 5 to 7 mil per kg. Minute ventilation is the amount of the air entering lung during inspiration over 1 minute. So it's respiratory rate time tidal volume. So minute ventilation decrease if the slow respiratory rate, and decrease also when there is small tidal volume, but also increased when the respiratory is high. So the tidal minute ventilation also decrease when the respiratory rate is high. So if your respiratory rate is 80, there is no time for air to go in and out, and tidal volume will be affected. So remember, tidal volume affect minute ventilation more than the respiratory rate. So when you have high respiratory rate, that will not be affected because the minute ventilation depend mainly on tidal volume. So I'll give you an example. If your respiratory rate is 80 and tidal volume is 3, so 80 times 3, that's 280 mil per minute. But if your respirator is 60, but your tidal volume is 7, so 60 times 7, that will be 420. So imagine how the tidal volume affect the minute ventilation. So remember, fast breathing is not good. So if you have fast breathing, you have to slow baby down, whether you're ventilated or not. And how you do that? You sedate the baby. So it's very important to know this fact. Questions? Because things are going to be more difficult. Any question? I can slow down. I can explain.
Yes, Doctor, just can you repeat the minute ventilation?
Minute ventilation, let's speak about tidal volume. Tidal volume is amount of air going inside the lung per 1 cycle. And usually it's 5 to 7 mil per kg. So for 10 kilo baby, it's 50 to 70 mil. In a newborn baby, it's 3.5 to 5 mil. Minute ventilation is amount of air entering the lung during expiration over 1 minute. And minute ventilation gives you the trend of the baby, while the 1 cycle gives you the dynamic of the volume. How the volume change in 1 cycle, the dynamic of that. We will learn that in the loops and graphics when we take ventilation. But the minute ventilation, we measure it because it gives us the trend over a long period of time. Minute ventilation, therefore, it affected by respiratory rate and tidal volume. minute ventilation affected by tidal volume more than the respiratory rate. So the respiratory rate affects the minute ventilation less than the effect of tidal volume. So when the respiratory rate slow, you get less tidal volume, but not as much as when you get the respiratory high, because when the respiratory rate gets low, you get less tidal volume. But also when your respiratory rate go high, you get less minute ventilation. The reason is because you don't have time to get enough tidal volume. And remember, we said tidal volume affect minute ventilation more than the respiratory rate. So minute ventilation decrease when your respiratory rate is slow, when your respiratory rate gets high, and when your tidal volume gets smaller. Now, I want to tell you fact here, and you don't need to know it now, you have to know it during ventilation. The volume is flow of time. What does that mean? Mean that if you want to inflate a balloon, you need time. Okay, so to get volume in the balloon, you need time. So volume is flow against time, or flow times the time. Pressure, however, is the speed of the flow. So if you want to hit somebody and you knock him down, you need to hit him as fast as possible. The more fast you get more pressure, you will knock him down. Okay? So if you want to push a paper, you need to push the paper very fast because you need pressure. And that's why when you are on a highway and you see a truck move by, you will get pressure. There is air will push you, especially after that, because there will be Venturi principle. We'll talk about that later. But remember, volume mean time, and pressure mean fast, mean speed. And that's why when you have more time, because your rate's slow, you get more tidal volume, because volume need time. Okay? So when the heart rate or the respiratory rate goes high, you don't have time for the volume to build in. And that's why you get less tidal volume when your respiratory rate is high. Once you get less tidal volume, you get less minute ventilation. Am I clear, or I confused you?
Clear, doctor.
Great. Okay, and then you guys will learn more about this because we'll repeat again and again and again. And then we'll start see cases, you'll learn more. It's not easy because this is your first time. Okay, and then we said breathing, we assess, if you guys remember, we assess expansion, we assess symmetry, we assess work of breathing. Okay, we assess respiratory rate, we assess tidal volume, and so on. One of the way we assess breathing is by oxygen saturation, by pulse oximetry. And remember, oxygen saturation measures the oxygen attached to the hemoglobin. It measures the oxyhemoglobin. It is the same principle of oxygen curve, if you guys remember, that we will learn when I was in medical school. Now, factor affect oxygen saturation because it measures the oxygen carried by hemoglobin in the periphery. So the more perfusion, the better reading. The less perfusion, the less reading. When perfusion affected, you will have irregular wave or you have poor wave. And remember, oxygen saturation is the percentage of the hemoglobin that is attached to the oxygen from total hemoglobin. So it does not measure the unoxygenated hemoglobin. Whatever the reason for being unoxygenated, whether you are carboxyhemoglobin attached to carbon dioxide, or you are methemoglobin attached to carbon monoxide, or you are abnormal hemoglobin, such as silver hemoglobin, or M hemoglobin, or S hemoglobin, you cannot measure it. You just measure the percentage of the oxyhemoglobin from total. And remember, it does not measure the oxygen in the tissue. And it does not measure the oxygen dissolved in a plasma. It only measures the oxygen attached to the hemoglobin. And it does not measure the CO2. And remember, in the lung, we have oxygenation and ventilation. When we say ventilation, we are talking about the level of CO2. So when I say ventilate the baby, mean wash CO2. Oxygenate the baby, mean increase PEEP or give oxygen. Pulse saturation measured should be more than 94 in an infant, and when it's less than 90 is abnormal. And in a premature baby is 88 to 93, and when it's less than 85, it's abnormal. Remember, you don't need to give oxygen more than 94. It's toxic. In premature baby, you don't need more than 93. Because saturation measure percentage. And when you measure percentage, any percentage, when you go to the extremity, you get margin of error. So for example, if you have a scale, and this scale used to measure fruit, for example, the grocery guy can cheat you very easy, because if you bring a scale that can measure up to 200 and you want to measure half kilo, the margin of error is very high, because 200 scale, the best measurement is when you measure 100 kilo. When you measure 101 and 99, you have a margin of error. When you measure 98 and 12, there is margin of error. When you measure 110 and 90, you have margin of error. And therefore, above 93, above 94, and below 50, the margin of error is very high. So we don't know what is the number. So the best measurement for saturation is when you are between 70 and 94. Anything above 94, it can be 94, it can be 100. And remember, we never want the baby to breathe more than 94. The reason is because we are giving oxygen, and oxygen is toxic to the body. Why? Because it converts to oxygen radical. And when it's converted to oxygen radical, it's accumulating in the body, like H2O2, like O1. Okay? These radicals cannot be moved from the body. We are not fish. The fish can move the radicals because they have hemopyroxene. We don't have hemopyroxene. We cannot move the radicals. So we cannot give oxygen to the baby. Oxygen causes death. In adult, you cannot give oxygen directly from the... There is a human right. Human rights are 3 in oxygen. Should be heated, should be humidified, should be blended. You cannot give oxygen directly from the oxygen bottle. That is wrong. This causes death or sickness. What oxygen radical cause when it accumulates in the body, it causes myocarditis, it causes pneumonitis, it causes enteritis, it causes nephritis, it causes cerebritis. And if you oxygen, pure oxygen to a human being, more than 3 days, they will die. Now, am I clear?
Yes, clear, dear doctor.
Yeah. And so what is the human right? It should be heated, blended, humidified. So how we blend? We put air, medical air, and oxygen, and we put air oxygen blender. Okay. We cannot measure oxygen by flow like what we do. Oxygen is only given temporarily and by mask. We cannot continue oxygen to a human being more than 15 minutes, because that is wrong. Whenever you need more than 30% FiO2, then there is something wrong, either in you or in the baby or in the machine. You need to fix it. So that's why I hate the word give oxygen. And I think in the textbook should be changed to give respiratory support. So remember the pulse oximetry. It measures the oxyhemoglobin. And it measures also, remember, the perfusion. And remember, it does not measure the tissue. And remember, it does not measure the oxygen dissolved in the plasma. that is measured by blood gas. And remember, it does not measure any unoxygenated hemoglobin. Any question? And we reach circulation, and I'm going to stop here. So we did initial assessment, identify, evaluate, identify, intervene. And now we're doing the primary assessment, and it's A, B, C, D, E, F. We talked about A, how we evaluate, identify, intervene, and we talked about breathing, identify, evaluate, and now we reach to circulation. And I'm going to stop here. And I'm happy to take questions. If there is any difficulty, am I moving very fast, slow? Do you find difficulty? Are you learning? Please comment. Feel free, absolutely free. I'm very open to comment, and that's the way I learn. Okay, I learn only when